be introducing the new kid on the block, and that's CT stress perfusion. CT perfusion is obviously the new gatekeeper. And if you look at this paper in the NEJM in 2010, you will clearly see that if you did not have a good gatekeeper, only 37% of the cases that you sent to the cath lab had an obstructive CAD. So the need of the hour is obviously a good gatekeeper. Now CT is great. It's great for sensitivity, but what it really lacks, as you can see, is the green bars, is the specificity. And the similar picture is with its cohorts, the SPECT and PET. And if you look at the FAME2 and the COURAGE trials, it has clearly come out that a pure anatomic test cannot adequately predict the hemodynamic relevance of coronary lesions, and therefore functional assessment of myocardial perfusion is important. Now, what does CTA bring to the table? Foremost, it brings plaque and lumen imaging, and we know that they play an important role in ACS. Secondly, lesion level hemodynamics, as Dr. Ravi has very eloquently brought to you by the FFR CT. And lastly, it does bring perfusion imaging. Now, functional analysis by CT is by two techniques, the CT FFR and by myocardial CT perfusion. Now, myocardial CT perfusion can be done by basically two techniques, the static technique where you look at myocardial blood flow at one point in the cardiac cycle, and that is determined by a single energy CT if you have a 64 slice, and a dual energy CT if you have a dual source scanner. Now the dynamic perfusion is much more challenging, but it brings to the table multiple points in the cardiac cycle, and therefore what you get is myocardial blood flow, which was previously in the realm of the PET scan, as Dr. Patel has clearly told us. Now what about perfusion physiology? Well, it all depends on the adenosine that you use, and then you give the contrast as you do normally, and using the first pass technique, you look at attenuation, and that suggests the reduced or decreased perfusion. And you can see that in a patient here with the single source scanner, the LAD area has a hypoattenuation, and using a different iron map in a dual energy scanner, you can see the same thing. What dynamic perfusion brings to the table is it gets you structure, but what is important, it gets you actual numbers of myocardial blood flow. As you can see here in green, you get a higher blood flow, and in blue, where there is a lesion, you get a lower blood flow. So exact quantitation of blood flow is there. And when you start getting blood flow, you start getting cutoff values, which can be used in patients in a sequential manner or in research studies for both segmental and global level. What it also does bring beyond the PET scan is the transmural perfusion ratio because of its excellent spatial resolution. So you can actually look at blood flow in the subendocardium versus the subepicardium, and any value more than 1 is normal. Now, what about patient preparation? Well, it's nil per mouth for about 4 hours. Clear liquids are allowed. Oral beta blocker is mandatory. You need 2 IV lines between 18 and 20 gauge, one for the contrast injection, the other one for the adenosine infusion, or if you're using regonosine, then it's a bolus, and we use adenosine in India because of its availability. Continuous ECG and blood pressure monitoring is mandatory in the CT suite, and it's not a major problem like you have in the MR suite. Beta blocker is mandatory, and it enables prospective ECG triggering in the REST scan, and obviously, as we all know, it improves image quality. We do give a small beta blockade even in the stress study because we're using adenosine. That way you avoid the motion artifacts and you avoid misalignment artifacts, which is the bane for the perfusion studies. Adenosine is what we use. You do get a jump up in the heart rate, as is well known in nuclear studies. So we give a small touch of beta blocker to prevent that jump. In the end, with a well-prepared patient, you get exquisite images of both structure, that's the coronary, and you get these very good color plots talking about the perfusion. You need a dedicated lab for this. You need about 45 minutes of time to do the stress and rest, and you need a very well-tuned team. Now, what about the protocols that we use? Well, there are two schools of thought. The first is where you use a rest CT protocol, and the second is you do the stress first, and then finally you get to do the late enhancement CT at the end of 30 minutes. Now, the stress perfusion first and then the rest perfusion has its advantages. in that you have a well-established team doing it on a regular basis, so you don't miss anything. You don't have to use a lot of beta blocker to prevent the ischemia cascade, and also you don't get contrast contamination. Now, the proponents of the rest perfusion first is that if you do get a normal CTA, you don't have to do the second scan. And the other advantage is that there's a reduction in radiation. Now, what about post-processing? The post-processing is very crucial, and it takes time, and there is a fairly long curve to acquire that kind of excellence that is required. The few important points are that you need to acquire images rapidly, because by slow acquisition, you tend to miss the iodine peak. In a static image, you need to pick up the peak iodine dose, which sometimes can be difficult. Recognition of artifacts is important. Use of beta blocker again is crucial. And then the reconstruction again is not there in all the systems. CT perfusion is in the realm of a very niche group of institutions and imagers. Now, the way to acquire it is multiple. If you have a dual source scanner, you can use a dual energy sequence with using iodine maps at different energies. You can use static if you have only a 64 slice system, and you can use dynamic if you have a 320 slice system, which is something that we would like, because you get accurate and numbered myocardial blood flow. The workstation settings, what is most important is please use the minimum intensity projection, very thin slices, and all available RR intervals have to be used, and it has to be projected in the 17 segment model like SPECT. Now, what about the competitors? You heard all of them today evening, CMR, nuclear, and echo. And well, CT perfusion stands the test of all of them, and you can clearly see with respect to SPECT in terms of rest images and in stress, clearly showing you that it is a fixed defect suggestive of an infarct both in the LAD and the RCA. And here you can see a small perfusion defect in rest and a large defect in stress suggestive of a large inducible ischemia in the LAD, perfectly mirrored in the SPECT. But what is also important is you get to see the much better spatial resolution compared to the SPECT images. What about the gold standard MR? You can clearly see that the spatial resolution mirrors this, but what is even more important, if there is ischemia in the PAP muscle, you get to see that on CT, and it's not very well seen on MR. And again, the correlation with SPECT is really excellent in the infralateral wall in this patient in L6 territory. The data, again, is fairly robust in that CMR and CT perfusion are very similar. They are non-inferior technologies, but I believe the real rival is CT FFR. And CT FFR, as we know, is an indirect measure of myocardial ischemia, but CT perfusion is a direct measure of perfusion. And what is more important is you get to know the microcirculatory perfusion in CT perfusion. FFR is the more famous brother. As you know, the Discover Flow de facto in the next trials really has put FFR CT on the map, and Dr. Patina has really shown that. But when you actually add these two technologies together, you get an excellent diagnostic accuracy of almost 80% and the largest area under the curve compared to if you use them separately. If you look at the MACE, you can clearly see that whatever technique you use, the MACE are very similar. And in fact, there is a slight edge in CT perfusion compared to FFR. Now, this is where things change. When you have a high calcium score, the image quality comes down, and with that, the CT FFR ability to measure really comes down, because it all depends on a good quality scan. And here you will see the accuracy, both sensitivity and specificity, remain true in CT perfusion because it doesn't depend on the calcium. And when you look at the invasive FFR data, again, you can see there is robust agreement with that. What is even more important is that CT perfusion mirrors the prognosis, and if you have a patient with a negative CT perfusion, the survival curve is excellent, while if you have a positive CT perfusion, then the MACE event starts rising, and it mirrors if when you do invasive angiogram versus a SPECT. So 2 techniques versus 1 technique. So whether you use the lesions on the CT perfusion or if you use the perfusion, the prognosis seems to be excellent, and by using perfusion, you get to see a very, very accurate prognosis. Tying everything together, we'll move on to our case presentation. And what is fundamental here is the right patient, and that has been enunciated by all the speakers. You need to look at patients who are CAD-RADS3 on coronary CT, or what we commonly call intermediate patients and intermediate lesions. Not appropriate in patients with ACS, not appropriate in patients who have allergies to drugs like beta blockers, who have atrial fibrillation, who have AKI, or where you cannot give vasodilatory stress. And our first patient is a 49-year-old male. He has class 2 angina. He is hypertensive. The CT lesion was borderline 40 to 60 or 50 to 70. We did a cath, again borderline lesion. Did the CT perfusion. You find the anterior septum has a perfusion defect, and therefore this lesion is actually hemodynamically significant. During the PCI, they did an FFR which was 0.7, and therefore went ahead with the PCI. Second patient is a 59-year-old lady, class 3 angina, diabetic, hypertensive, did the CTA, got a mild plaque, it's non-obstructive, other vessels are normal in the LAD. The CT perfusion showed a global perfusion defect, suggesting a microvascular angina or a microperfusion problem. And this patient was managed aggressively with optimal medical therapy with the addition of nicorandil. 68-year-old male, prior PCI to LAD with class 3 angina. He's a smoker. We did the CT, mild ISR in the stent, but we also found an occluded D1. And again, the perfusion sequences clearly show that there's a large perfusion defect in the anterolateral wall or the diagonal territory. And the team went ahead and did a POBA to be diagnosed. This is a 78-year-old lady with angina, class 2, diabetic. We did a CT, multiple calcified plaques, difficult to really tell. Did the CT perfusion, large perfusion defect here in the anterior septum, and PCI to LAD was done with good result. Now, where does FFR and CT work? Now, there is a very good correlation with FFR and CT perfusion. When FFR says positive, CT perfusion also is generally positive. There are times when the FFR will be positive and CT perfusion would miss it, especially in obese patients, especially when there are significant collaterals where the myocardial perfusion actually is preserved. And the third group where you will have FFR negative, but the CT is perfusion. And this is a real place where you would really interpose CT perfusion, especially in middle-aged ladies with microvascular angina, and also in patients with left ventricular hypertrophy, where there are mild lesions but significant mismatch between the demand and supply. So ladies and gentlemen, in summary, non-invasive modalities to evaluate chest discomfort need to act as effective gatekeepers for invasive angiography. Otherwise, we'll be left with that 37% of PCIs only. Coronary CTA and CT myocardial perfusion is a new kid on the block, but it does offer the option of providing anatomical and functional information in one test. In about 30 to 45 minutes, you've completed the test and the patient can go home, and the processing takes about 1 hour. So CT myocardial perfusion, according to me, has a favorable specificity. It's got a good positive predictive value and an excellent negative predictive value in CAD-RADS3 lesions or intermediate patients and intermediate lesions. Thank you very much.